this is about a patient who had injury by some quarrel, and a patient have been beaten up by some wooden rods, and there was initially only laceration in front of the knee joint. The treating primary physician had just sutured the wound and sent the patient. Patient somehow had the pain, but he was not able to lift his legs. So he approached us, and we found that the patellar tendon was avulsed, and it is one of the rare occurrences without any cut, only by blunt injury, the tendon getting ruptured. So usually patellar tendon gets spontaneously ruptured because of some metabolic diseases and some collagen diseases in elderly people, because of weak tendon and because of sudden weight loading. It happens. So that is relatively less common, but that happens, and that's reported in the literature. But the current scenario is traumatic rupture of patellar tendon, and that too from the tibia without any fracture. It's kind of soft tissue injury, sparing the bones and only causing injury to the tendon. So this is only 4 or 5 case reports were seen, and those reports, they were using metal hardwares, and we tried to incorporate our learnings from the shoulder joint surgery and using these anchors. So nowadays anchors are providing more equally good tensile strength like that of the metals. Usually for the knee joint to extend, we must have wait a minute. So for the knee joint to extend, we must have intact quadriceps tendon, then the patella and the patellar tendon. So everything should be normal, and of course the tibial tubercle. In our case, everything is normal, quadriceps tendon, patellar retinaculum, patella, but the patellar tendon was avulsed completely. So here, if you see the mechanism of knee joint flexion and extension, so you could see that proper movement of the knee joint needs everything intact, the patella, quadriceps tendon, and the bone, everything. Okay, in our case, so now I'm asking the patient to lift the leg, even though there was no obvious external injury. Patient is trying, he is not able to do. Now in lying position, he is trying to lift the legs away from the bed, but he's not able to do. If he's asked to flex, he will be doing, but when he's asked to extend, he's not able to do. Only with the support, if I lift, then that's fine, but he's not able to do on himself. And then we did the scannings, MRI. MRI showed, see, usually here you see on the left hand side of the picture, patella and then patellar tendon, it getting attached to the tibia. See the right hand side, our patient, unfortunately the tendon got completely torn at the level of tibial tuberosity. So he was not able to do the activity, and also patella was seen at a higher level, that's called patella alta. So at the arrow mark, the tendon got ruptured. This is another T1 weighted image. We could see that the tendon is ruptured and it got retracted. So here we have options. Since it is a suture, we have to connect the bone and the tissue. So usually direct suturing is difficult, and we can take bite through the bone, but it's a bit difficult. So this was the case scenario. It was sutured wound by the primary. It was superficial laceration, not deep enough inside the bone. So once we do surgery, if we open, we could see that the tendon was completely avulsed and the distal part of the femur was seen. But fortunately, since the intervention was early, within a matter of 2 weeks, the tendon did not get kind of atrophied or retracted. So we could able to replace it in the tibial tuberosity at the correct length in correct tension. And there was no need for any external augmentation from any other graft, or Achilles tendon or autograft or allograft was not necessary. We could do direct suturing. So here we used these kind of suture anchors. In the right hand side, if you see inside the bone, the anchor will go and the threads will come out. On whatever tissue we want to hold, we can hold it with those tissues. So these are latest things are without metal also available, but we used for economical constraint, we used metal anchors. So we made some space in the tibia, and the anchor was placed inside. So from the anchor, the tissues, there was suture, and we take bites in the patellar tendon. This is a normal technique, like any other suturing. For Achilles tendon, we used to do Krakos and Kessler's kind of suture. This is one such kind of modification. So after the suturing, so also we did end-to-end repair of the remaining meager tissues. We did that repair also. So after that, we found that few tissues are lifted off. So in order to cover those also, we put an additional anchor. This is a small size anchor. So that was placed, and a final construct was made. So here the point to emphasize is the use of sutures instead of any metals. So after final repair, we were very happy that the patella was reasonably moving like that of the normal joint. Since we augmented with the additional sutures, it was very stable. So this is the routine technique, usual way of augmenting. After suturing, people used to put this metal wires inside. That causes when patient kneels down, or they will have pain on extreme knee flexion when they squat, or sometimes on climbing stairs as well. So this was the picture. So these sutures were not visible in the X-ray, and only metal anchors were seen. So also you could see the patella has been at a lower position, and there is no patella alta here. Rehabilitation plays an important role in these kind of injuries, especially the patient is as such he's a football player and he wanted to return to sports. So we faced it in immediate period is mainly the protection phase, where we have to prevent the dehiscence of the wound. So we just made the patient with limited weight bearing and with braces. From next phase, with protection, we tried to move, and gradually with the last phase, after 3 months, patient was able to do further activities. Yeah, initially only bedside movements, and with belt, patient was doing little activities. The next level, he was doing the next level of resistance exercises. And final phase, he was doing gym activities. It's about 3 months, beyond 3 months, hamstring curls and all kind of stretching, hamstring and quadricep stretching and tendon stretching. So at 3 months follow-up, if you could see, initially he was not able to lift the leg. Now he's able to actively do, even with some weights also, he was able to do at 3 months itself. And straight leg raising also possible. Yeah. So to conclude, means as a discussion part, usually what happens after this kind of surgeries, if we do delayed, or if you are not doing at a correct tensile strength, if the isometry is not maintained, we should tighten it in full extension. Rather, if we tighten all the sutures in flexion, patient cannot do extension. So these are the minute points, and patient can land up in knee stiffness, or sometimes because it's a superficial thing, patient can get infection. Fortunately, our patient did not have any of those complications, and timing of repair is more important. So to conclude, avulsion of patellar tendon from tibial tubercle is uncommon, and it's a unique challenge since sutures cannot be easily placed inside the bone in a transosseous fashion. And detailed clinical examination is important. Sometimes we may ignore saying that it's only knee pain and you do physiotherapy and that kind of stuff, because we should not do that. And timing of surgery is important. If we delay the surgery, the tendons will get atrophied, and later it is difficult to do primary repair. We need some kind of augmentation. And yeah, of course, the suture anchors provide, these are the latest advancements. Suture anchors provide sufficient strength to carry out immediate rehabilitation program, and it prevents hardware irritation as well. And yeah, finally, guided rehabilitation is important for the best outcomes. Thank you very much.